Welcome everyone for the class on ECG. So it is a part 2 continuation of the ECG where we had left in the last class. So in today's class, mainly we're looking at the rhythm of the heart. In little sense, what does the rhythm means? Rhythm means, where is it originating from? Where is the electrical activity in the heart is originating from? Is meaning of the rhythm. Is this electrical activity which is originating, is it uniformly regulating, or basically you need to ask yourself, is it regular or is it irregular? So two things we are asking ourselves whenever we are questioning about the rhythm of the heart is, where does the electrical activity originate? And is this electrical activity which is originating, is it regular or is it irregular? We know that most of the time in a healthy individual, it is the SA node, which is the pacemaker. So the electrical activity arises from the SA node, goes to the AV node. There is a fraction of time delay in the AV node. Once from AV node, the electrical activity passes into the bundle of His, divides into right and left bundle branch. Okay, sometimes the electrical activity will doesn't go in this same electrical pathway. That means it may not be generated from an SA node at all. It might get generated somewhere from the atrial muscle, somewhere around the AV node known as AV nodal rhythm, or junctional rhythm. They all mean the same. So anything which is arising above the ventricle, in general, it is known as supraventricular. If the electrical activity is originating above the ventricles, it is known as supraventricular tachycardia. And this supraventricular tachycardia, whenever there is a originating anywhere, for example, it is originating here. From here, it passes to the AV node, then it enters to the normal pathway. As it is passing through the normal pathway, the QRS morphology will remain the same. The QRS, what you are seeing, will remain the normal itself, the QRS morphology. There will be no change. If the electrical activity is originating from the ventricles, it doesn't enter into the normal electrical pathway at all. That's why the QRS complex becomes bizarre. You'll not be able to appreciate the Q wave or R wave of the S wave, and usually they will be broad complex because it is not coming through the normal electrical pathway. So there is no synchrony on what is present there. That's why it takes more time for the ventricle to contract, because the electrical activity is not passing in the normal electrical pathway. That's why there is a broad QRS complex, what you see in all ventricular rhythms. So remember supraventricular normal morphology. So the rhythm can arise from a SA node, from an atrial muscle, or anywhere around the AV node, that is also known as nodal rhythm or also known as junctional rhythm. Or else it can arise somewhere from the ventricle muscle itself, but the QRS complex will be quite bizarre. You'll not be able to appreciate the Q, R, or S wave. So each one of these arrhythmias, let's see the pathologies, what we are seeing now. Sinus arrhythmia. Sinus is the rhythm what is saying. So it is arising from the SA node itself. It is not arising somewhere else. It is arising from the SA node itself. Arrhythmia. Arrhythmia means irregularity. So in a literal sense, if you ask me, it is nothing but dance. It's like someone is dancing. It is irregular what is present. So sinus. So there is a P wave. Always there is a P wave which is present. After a P wave, there is a QRS complex which is present. So it is an sinus rhythm what the patient is in. But the rhythm is irregular. If you compare this RR interval compared to this one, it is different. Compare this RR interval to this one, it is different. Because it is different, the RR interval is changing from time to time. That's why we call it as an sinus arrhythmia. Sinus, because it is arising from the SA node. Arrhythmia, because the rhythm is irregular. Sinus bradycardia. Any bradycardias from our draft chapter, we are aware that we always ask two questions for ourselves. Does every QRS complex has a P wave? This lead will take it. QRS complex P wave, yes, 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 and yes. So does every P wave have the QRS complex? Again, it is true, true, and true, and true, and true. So it has to be either sinus bradycardia because the heart rate is on the lower side, or first degree heart block. For that, we look at the PR interval. PR interval seems to be less than one large box. That's why it is not at first degree heart block. It has to be sinus bradycardia because the heart rate seems to be very low, less than 60. Let's calculate approximately and see what is the heart rate. 1, 2, 3, 4, 5, 6, 7, 8. So 300 divided by 8 you are having. So heart rate is on the very lower side what you are having here. Obviously less than 60. That's why we call it as in sinus bradycardia. sick sinus syndrome. It is also known as Brady-Takey syndrome. What happens? As the name suggests itself, in a literal sense, the sinus, the SA node is sick. That means sometimes it transmits the electrical activity, sometimes it doesn't transmit the electrical activity at all. It gives and pause completely. There will be a pause. So let us see the ECG what we are having. So we are having a P wave here, and QRS, and suddenly there is a pause. There is no P wave at all. There is no QRS complex at all. That means there is literally no electrical activity which is happening here. When there is literally no electrical activity is happening, that means it's sick sinus. That means the SN node has paused in between. Suddenly it starts again with the normal electrical activity. That's why it is also known as Brady-Takey syndrome. They mean one and the same. Do not get confused. Both are one and the same. So what happens? There will be complete no electrical activity. Do not get confused with Morbius type 1 or type 2 block. Here there is complete. There is no P wave seen at all. That's why we call it as in sick sinus syndrome. Slow rhythms. In slow rhythms, bradycardias we are entering into the slow rhythms, what we are entering into. Blocks we have already dealt with in the last class. Let's just see what is atrial escape. Atrial escape basically means there is a escape in the atrial. That means basically what does it mean? It arises from the SA node itself. It goes to the AV node into the bundle of his. So normal electrical activity it is passing. In between from an atrial muscle, there is an electrical activity which gets generated, which is not arriving from the SA node at all. That means this electrical activity is abnormal. That's why the P wave morphology will be bizarre. If the P wave morphology is bizarre, this electrical activity is basically not arising from the SA node, somewhere from the atrial muscle itself that can produce an ventricular contractions. This P wave is nothing but an extrasystole what I am having, also known as an escape. So the atrial rhythm of the electrical activity has escaped from a normal electrical pathway and resulted in a bizarre P wave. What is junctional escape? Junctional escape or junctional rhythm means the electrical activity is arising somewhere around the AV node. It is not arising from the SA node at all. If it is not arising from the SA node, it cannot be heart rate between 70 to 100 what we usually see. It will be between 40 to 60. Usually in that range what you will be getting the heart rate. So let us see an junctional rhythm. How does it look? Junctional rhythm, as it is arising from the AV node, some of the electrical activities will go into the atria, some of the electrical activities will go into the ventricle. Usually it will be going through the normal electrical pathway itself. So let me repeat what happens here in junctional rhythm. Electrical activity is generated around the AV node or from the AV node. This electrical activity will go to the atria, and at the same point of time, there is no delay. At the same point of time, it will enter into the normal electrical activity and produces the QRS complex. So most of the time, the P wave kind of overlaps the QRS complex here. So most of the time, you'll not be able to appreciate the P wave. If you are able to appreciate the P wave, it is usually inverted. So here we are seeing from here to here, what you can see here is no P wave is present. At the same point of time, rhythm is regular. So 2 points what you need to remember for junctional rhythm is P wave is absent. That is absent. It is not present. No P wave is there. And the rhythm is regular. And the heart rate is between 40 to 60 beats per minute. What is accelerated junctional rhythm? Accelerated junctional rhythm, if the heart rate is usually more than 100, we call it as an accelerated. Most of the time, it is between 60 to 100 or up to 120 also, we call it as a junctional rhythm. Okay, P waves are usually not seen. If seen, it will be seen in inferior wall leads or in an AVR, what you'll be seeing. AV dissociation can be present with the ventricular rate usually greater than the atrial rate. Okay, but it is difficult to appreciate. That means there is no association. That means usually atria is not contracting at the same rate of that of the ventricle, and ventricular rate is slightly on the higher side compared to that of the atria. Let us see an example so that we understand better. So in this ECG, what we are seeing, there is a P wave, yes, but P wave is inverted. That's what you need to remember. Is the rhythm regular? Yes, the rhythm is regular. What is the heart rate? Approximately, if you can consider, it is around 2.5 or something, 300 divided by 2.5, approximately 220 we can consider. Approximately, I'm not calculating accurately here. So this is considered as an accelerated junctional rhythm with AV dissociation. Why can't we call it this as an SVT, supraventricular tachycardia? The definition remains the same. There will be no P wave. Yes, no P wave is here. For example, in this ECG, if you are taking, there is no P wave. Yes, there is no P wave. Just take this complete strip. There is no obvious P wave what you can appreciate. At the same time, is the rhythm regular? Yes, the rhythm is regular. But how can I differentiate this from an supraventricular tachycardia? You can differentiate it on the rate. It is an accelerated junctional rhythm where the heart rate is usually less than or around 120, what we are expecting. If we calculate here, the rate is obviously on the lesser side. You can say for sure it is less than 150, if not lesser than that, because it is at least 2.5 blocks what you are having. If 2 blocks itself, 300 divided by 2 itself, it will be 150. It is less than 150. Supraventricular tachycardia, most of the time it will be more than 180, not even 150, it will be more than 180. So if it is the QQ waves, if you count the number of large boxes between two Q waves, if it is more than two large boxes, you can consider this as an supraventricular tachycardia. That's what you need to keep in mind is the heart rate, which will help you to differentiate between an junctional rhythm, accelerated junctional rhythm, and SVT. Junctional rhythm will be having a heart rate between 40 to 60. Accelerated junctional rhythm will be having heart rate between 160 to 120. Supraventricular tachycardia, you'll be having more than 120, more than 180 usually. Definition remains the same, no P wave and regular rhythm. Ventricular escape. Again, like an atrial escape, there can be a ventricular escape where an electrical activity is generated from one of the muscles of the ventricle. So suddenly it appears and it starts taking or making a pacemaker. This usually will happen in a complete heart block, which is also known as third degree heart block. Both means the same. Do not get confused. Whenever there is a complete heart block, there is literally no electrical activities coming down the normal electrical pathway. Then the ventricle muscles will start generating the electrical activity. That QRS complex usually will look quite bizarre, commonly seen in a complete heart block or third degree heart block. Means the same. There is no differentiation between complete heart block or third degree heart block. At the same point of time, let us see what is accelerated idioventricular rhythm. Accelerated idioventricular rhythm is commonly seen in myocardial infarction. It usually mimics or it confuses with ventricular tachycardia. What happens is, if this is the ventricle what you are having, if this is undergoing infarction due to the myocardial infarction, obviously, this part of the muscle can generate the electrical activity and produce a rhythm which very much looks like an VT. Okay. How to differentiate it? The heart rate is usually between 130 to 150 beats per minute. Then you will consider it as an accelerated idioventricular rhythm. What you need to consider in the stem of the question or in your real life also. This is an myocardial infarction. For example, it might be an ST segment elevation myocardial infarction patient what you are having. Okay. And the patient is completely stable. His blood pressure is fine. What you're seeing on the monitor, blood pressure is fine. He's not breathless at all. At that point of time, suddenly on the monitor, you start seeing this rhythm and the heart rate is less than 150 or between 130 to 150. In that range it is. The patient is stable. It is a case of myocardial infarction. Do not do anything. Do not intervene. Do not give a shock or start giving medications. This is a benign condition. Do not touch this condition. If you just recannulate the patient, this condition will disappear. You need not do anything particularly to stop this rhythm. This is a benign lesion. Do not touch this patient. For example, if you consider this as a stable VT and end up giving an amiodarone, can have an amiodarone effect. Every anti-arrhythmic can predispose to an arrhythmia. Remember that point. That's why when you're giving an anti-arrhythmic drug, you should be doubly careful while giving the drug. You give an amiodarone can predispose to any other rhythms and it can be a disaster. So remember this. This is known as accelerated idioventricular rhythm, will be helpful in your regular practice also. Ventricular extrasystoles, also known as premature ventricular contractions, PVCs we call it more commonly. So what happens? Normally, the electrical activity from SA node, it goes to the AV node and bundle of phase and divides into two branches. So the normal electrical pathway is working wonderfully well. Suddenly, there is an electrical activity which is produced in the ventricular muscle that will appear as a bizarre QRS complex. Most of the time, they are benign. We are not worried about it at all unless and until it overlaps the T wave. This is known as R on T phenomena. That means a QRS complex, the electrical activity it is generated from the ventricle, that QRS complex, if it overlaps an T wave, then it can trigger an VT or VF, that is ventricular tachycardia or ventricular fibrillation. That's why whenever you see an PVC, have a closer look whether it is overlapping the T wave or not. If it is overlapping the T wave, then you need to immediately involve the cardiologist and let them know what needs to be done. You need to take cardiologist opinion for this. For this, it is not required. It is a benign thing. It is seen in many healthy adults and elderly people. You need not intervene. Nothing needs to be done for ventricular extrasystoles. Now we are entering into the tachycardia. Tachycardia is nothing but fast rhythm. Whenever we are analyzing and fast rhythm, one thing what we'll be looking at most importance is how is the QRS complex? Is the QRS complex broad or is the QRS complex narrow? Broad, we call it if it is more than 3 small boxes. Narrow, we'll call it if it is less than 3 small boxes. Why is it helpful? If it is narrow QRS complex, we are considering it as an supraventricular rhythm. Supraventricular rhythm can be atrial fibrillation. It can be an atrial flutter. It can be an supraventricular tachycardia. This can be just an sinus tachycardia. These are the differential diagnoses. So easier it becomes. If it is an ventricular rhythm, it becomes broad QRS complex. If it is a broad QRS complex, then again we are thinking whether it is a monomorphic ventricular tachycardia, whether it is an polymorphic ventricular tachycardia, or whether it is an ventricular fibrillation. That is very important to us. For that particular reason, we always look for QRS complex. So always look for the QRS complex, whether it is a broad or narrow. There are exceptions which we'll be seeing in coming up slides. First, let us see what is atrial flutter. Atrial flutter is basically, it is fluttering. It is just vibrating. It is like vibration of the ventricles, what you are having. There might be some contractions also. Okay, it is not literally vibrations. Literal vibrations is more often fibrillation. Flutters is basically there are multiple electrical activities which are arising from the atria. Only few are transmitted through the AV node. As only few are transmitted, it is transmitting in a good ratio. For example, in this is a P wave, this is a P wave, this is a P wave. For every 3 P wave, there is one QRS complex what you are having. So AV node usually transmits in a fixed ratio. Because of this presence of this P wave, it gives a classical appearance known as sawtooth appearance. So remember, this is known as sawtooth appearance, which is very important for you to remember. Now we are getting into supraventricular tachycardias. Supraventricular tachycardias, as described previously, you need to remember there will be no P wave. You're not appreciating P wave mainly because the heart rate is so high, you will not be able to appreciate. At the same point of time, rhythm is regular. Regular, what you need to remember. And the heart rate will be usually on the higher side, that is more than 180. These 3 points, what you need to remember, will help to differentiate from any other rhythm. This is known as supraventricular tachycardia. Let's break down this ECG and have a look. So you are having an QRS complex. So what is this? Whenever there is an QRS complex, there has to be an P wave. It is not a P wave because there is a depolarization. QRS complex represents the depolarization. If there is depolarization, there has to be an repolarization. And the ventricular muscle is a large chunk of muscle. So there has to be an repolarization. So T wave will be seen. So this is T wave what you are having. After that, if there is one more positive deflection before an QRS complex, then you call it as an P wave. So you cannot appreciate anywhere from here to here a P wave at all. So what you are saying is uniform or a regular rhythm what you are having, and the QRS complex is narrow. No P wave is seen. So QRS complex is narrow, no P wave is seen, rhythm is regular, and the heart rate is obviously on the very higher side. You can take it as one slightly more than 1.5. So it is more than 250 for sure. So very high heart rate this patient is having. So what happens in supraventricular tachycardia? Most of the time, the pathology is because of AV nodal re-entry tachycardia. So what happens in this pathology? Usually the electrical activity from SA node is the SA node enters into the AV node. So this whole thing is AV node. AV node has two paths. One is fast path, another one is slow path. Electrical activity enters into the both the paths. One enters into the slow path, another enters into the fast path. As the name suggests, fast path, it goes very rapidly, and some of the electrical activity goes down into the bundle of phase, and some of the electrical activity goes into the slow pathway and negates or basically cancels the electrical activity which has entered into the slow pathway. This is how usually regularly healthy AV node works. Due to some pathology, if there is an block in the fast pathway to enter the electrical activity from an SA node. From an SA node, the electrical activity is not entering into the fast pathway at all. It is just entering into the slow pathway. If it just enter into the slow pathway, what happens? Some of the electrical activity will go down into the bundle of phase. Some of the electrical activity will enter into the fast pathway. So it will go rapidly and re-enter into the slow pathway again. So this loop continues and continues and continues. Because it is looping around, the electrical activity what is generated increases. That's why the heart rate also increases. This is known as AV node re-entry circuit. This is the usual most commonest pathology for supraventricular tachycardia. AV nodal re-entry tachycardia. It is also known as AVNRT, you can call it. This is the mechanism what happens most of the time, not always for supraventricular tachycardias. So again, we are seeing the same thing here. So what we are seeing, again, supraventricular tachycardias, what we are having, a narrow QRS complex. Yes. No P waves. Yes, there is no P wave at all. There is a T wave. Yes, there is a T wave what we are having, because this is after QRS complex, there has to be T wave. There is a T wave what we are having. Is the rhythm regular? Yes, the rhythm is regular. Is the heart rate more than 120? Yes. So again, it is in supraventricular tachycardia, this ECG. Just stressing the points, what we have learned here. Remember the mechanism. Sometimes they might test you. What is the most commonest pathology which leads to in supraventricular tachycardia? It's AV nodal re-entry tachycardia. One more ECG we are having, again, it is suggestive of an AV nodal re-entry tachycardia. What we are having, is there a P wave? Obviously, there is no P wave seen here. Lead 2, let us take it here. No P wave from here to here, what I am seeing. The rhythm is regular, QRS complex is narrow. Again, it is an supraventricular tachycardia. Now we are entering into the monomorphic ventricular tachycardia. Monomorphic. That means the morphology of the QRS complex remains same from one QRS complex to the another QRS complex. So this QRS complex morphology is same compared to this QRS complex or this QRS complex. That's why we call it as a monomorphic ventricular tachycardia. As the name suggests, the electrical activity is arising from the ventricular muscle. But at a single point, it is arising. It is not arising from anywhere else. So only a single point where the electrical activity is arising. That's why we call it as a monomorphic ventricular tachycardia. Ventricular tachycardia, because it is arising from a single site of the ventricular muscle where it is arising from. Monomorphic because the QRS complex morphology doesn't change from beat to beat. Compared to this, there is something known as polymorphic. The change here or the difference here is the morphology of the QRS complex usually changes from beat to beat. This morphology is quite different from this morphology, is quite different from this one compared to this one. That's why we call it as a polymorphic ventricular tachycardia. Most of the time, polymorphic ventricular tachycardia is predisposed by prolonged QT interval. So remember, prolonged QT interval, anyone has having for because of any cause. It can be anything. It can be hypocalcemia or hypomagnesemia. It can be because of the electrolyte imbalances, or it might be a congenital abnormality of QT prolongation. It might be, or some medications like a tricyclic antidepressant overdose it is causing, or a macrolide overdose it is causing. Anything which predisposes to QT prolongation, that can predispose to an polymorphic ventricular tachycardia. The triggering agent here is prolonged QT interval. Most commonest electrolyte imbalance which causes prolonged QT interval is hypomagnesemia. That's why whenever we see an polymorphic ventricular tachycardia in the ALS algorithm, they recommend you to give magnesium sulfate if the patient is stable. In between, we are having something known as non-sustained ventricular tachycardia. Everything mentioned in the name itself is present. It is quite self-explanatory. Non-sustained. So you are having a ventricular tachycardia. This is ventricular tachycardia, what you are having. Yes, ventricular tachycardia, because it is a monomorphic, QRS morphology is not changing. So monomorphic ventricular. Suddenly you are having a normal sinus rhythm. Again, some ventricular tachycardia, again, normal sinus rhythm. You might ask me here is, can't it be PVCs? Yes, it can be PVCs. If PVCs are more than 3 consecutive. So here, with the definition, 3 or more PVCs. If 2 PVCs come consecutively, it is fine. If 3P waves comes consecutively, then we call it or label it as a non-sustained ventricular tachycardia because it is not sustaining. After by itself, it goes back to the sinus rhythm. Suddenly, there is a ventricular tachycardia that is basically more than 3 PVCs are seen. After that, again, it is a sinus tachycardia. After that, after some time, it might be again, after few seconds or fraction of a second, again, there is a ventricular tachycardia. Again, there is a again, there is a sinus sinus rhythm. So sinus rhythm, ventricular tachycardia, sinus rhythm and ventricular tachycardia. It is alternating in between. That's why we call it as a non-sustained ventricular tachycardia. Here, if you give and here, if the patient is unstable, you can give unsynchronized shock. But if the patient is stable, then treat the underlying cause. Most of the time, 90% of the time, these patients will be quite stable. Treat the underlying cause of this patient. If there is no underlying cause, then beta blockers, what do you need to give? Most of the time, some electrolyte abnormalities this patient will be having. So treat the underlying cause. Okay, this doesn't follow the normal ALS algorithm. This is an exception for your normal ALS algorithm. What we'll be learning in the recitation chapter, this is an exception. Non-sustained ventricular tachycardia is an exception. Remember that this is the treatment. Unstable, synchronous cause. Stable, treat the underlying cause. Most of the time, 90% of the time, these patients are stable. Just treat the underlying cause. If you couldn't find, or in the stem of the question, they have not given you any underlying cause, then treat it with an beta blocker. Let us see this rhythm, what we are having here. This, is it a ventricular tachycardia? No, it is not a ventricular tachycardia. I call it as an SVT. Why are we calling it as an SVT, not an ventricular tachycardia, is the question what you need to ask for. That question we are answering here. So what happens whenever an supraventricular tachycardia plus there is an bundle branch block? It might be a right bundle branch block or an left bundle branch block. It can be any bundle branch block. If there is a bundle branch block, QRS complex will be broad. If there is a broad QRS complex mixed with an SVT, it looks like or appears like an ventricular tachycardia. So there are various things which will help you to differentiate from a proper ventricular tachycardia to that of an supraventricular tachycardia. Because supraventricular tachycardia should be associated with one of the blocks. If this RBBP, that is RSR dash pattern is seen or an M pattern is seen, then more likely this is because of an, if this is because of an supraventricular tachycardia with an aberrant block, or basically we call it as with an aberrant conduction. Extreme axis deviation, we are aware that AVR is exactly opposite to the cardiac axis. AVR becomes positive in extreme conditions. One of the typical example for AVR to become positive is ventricular tachycardia. If AVR is positive, think of ventricular tachycardia, unlikely it to be an SVT. If the QRS complex is very broad, usually we call QRS complex as broad if it is more than 3 small boxes. If it is more than 4 small boxes, that is 160 milliseconds. If it is more than that, the QRS complex is. That means it is a very broad QRS complex. It's more suggestive of, again, ventricular tachycardia. What is capture beat and fusion beat? In ventricular tachycardia, the electrical activity is generated from the ventricular muscle. We are already aware of it. Some electrical activity can still be generated from the SA node, can arise, go into the AV node, and can pass through a normal electrical activity, normal pathway. Okay. If it goes through a normal pathway, you will be seeing a normal QRS complex in between. Okay. When you see a normal QRS complex in between, this is known as capture beat. Okay. And if this normal QRS complex overlaps the abnormal QRS or the abnormal electrical activity which is produced in the ventricle, then it is known as fusion beat. Okay, capture beat and fusion beats are only seen in ventricular tachycardia because the rhythm here, abnormal rhythm is arising from ventricular muscle. In supraventricular tachycardia, the abnormal rhythm is arising above the ventricles. If it is arising above the ventricles, it has to enter into the same electrical pathway itself. If it is entering from the same electrical activity pathway and entering into the ventricles, that means they cannot be an capture or the fusion beat, because the rhythm itself or the electrical activity itself is arising from supraventricular, above the ventricle, that is from the atria. If it is arising from the atria, it cannot have a fusion beat or the capture beat. It can only be seen in ventricular rhythms, that is particularly ventricular tachycardia. So if a patient is having a capture beat or the fusion beat, think it is an ventricular tachycardia. So these are the differentiating factors what you need to remember. At the same point of time, I would like to stress here that one of these things might not be present, or majority of these things might not be present. One or two things only might be present, which is suggestive of an supraventricular tachycardia, or which is suggestive of an ventricular tachycardia. So need not all of these features need not be present in any given ECG. Okay, in exam point of view, usually they'll not ask you to say this, giving an ECG like this, giving an ECG, tell me whether it is an ventricular tachycardia or supraventricular tachycardia with the aberrant block. They do not usually ask in this manner because it is very difficult to pick it up. Usually they'll ask, what are the differentiating factors? In words, they'll be asking, so you need to remember this differentiating factors. So what will differentiate a VT from an SVT? They'll be asking, so you will be using these words to describe. That doesn't mean ECG might not come. Now, coming back to this ECG, what we are having, it is an supraventricular tachycardia. Why? I can see the M pattern here. I can see the M pattern here, suggestive of an LBBB. At the same point of time, as it is arising from supraventricular, arising from the atria, I can quite clearly appreciate the QRS morphology here, which cannot be appreciated from a ventricular tachycardia. Though the rhythm is regular, I still call it as a supraventricular tachycardia with an aberrant conduction. Okay, so remember this, capture bits, fusion bits are only seen in ventricular tachycardia. Very broad QRS complex also seen in only in ventricular tachycardia. Extreme axis deviation only seen in ventricular tachycardia. RBBB and LPBB morphology is only seen in SVT. If it is present, it is more suggestive of an SVT. In your practice or in your exam, ECG is given. If you are confused, always consider it as an ventricular tachycardia. More threatening kind of rhythm, always you need to consider and treat it as a more threatening arrhythmia what the patient is having. Now we are entering into the fibrillation. Fibrillation is nothing in the literal sense. It basically means vibration. Okay, it is just vibrating. Heart muscle here, if this is the atria what you are having, it's just vibrating. It is not contracting at all. It is just vibrating. There are multiple P waves are present, or multiple points of electrical activity is generated from the atria here. That's why what you're having, P waves not appreciated. In literal sense, this line what you are seeing is irregular. This is irregular. This is irregular. This is irregular. This is irregularity what you are seeing is because of multiple P waves. The morphology is very bizarre of those P waves, where we cannot appreciate and frankly tell that it is a P wave at all, because it is arising from the atrial muscles, from different fibers of the atrial muscles it is arising from. For that particular reason, the P waves you cannot clearly appreciate at all. Some of the P waves, electrical activity is generated, it's transmitted to AV node. Some it is not transmitted at all. So the rhythm also becomes irregular. So no P wave and rhythm becomes irregular, then you call it as an atrial fibrillation. In atrial fibrillation, as there is only the vibration what is happening, there is no contraction itself. The blood is in static state. It is stagnant there. Whenever something is stagnant, especially if the blood is stagnant, it is prone for clot formation. For that particular reason, whenever you are having an atrial fibrillation, clots can form because it is not contracting. It is just fibrillating. That means it is not contracting, it's just vibrating there. For that reason, clots are formed in an atrial fibrillation, and these clots can be thrown out into the circulation and can have an ischemic attack anywhere from the brain to your extremities to any organ can be there because of the atrial fibrillation. That's why the importance of atrial fibrillation, what you need to remember, heart rate doesn't matter. Heart rate might be well within the normal range itself. It might be 70, it might be 80. Sometimes heart rate might be very high. How to manage, we will be learning in cardiology chapter. So we'll be getting back here. We're just learning the ECGs. Ventricular fibrillation. Again, here the ventricles are just vibrating. They're not contracting at all. They're just vibrating. So the electrical activity is generated from multiple points of the ventricular muscles. Because of that, the ventricle is just vibrating. So bizarre what you're having. This is basically coarse. Sometimes it might be fine ventricular fibrillation. So there is a coarse ventricular fibrillation. There is a fine ventricular fibrillation, almost as systole. Whenever there is a ventricular fibrillation, we always consider the patient is in cardiac arrest. Why do we consider the patient is in cardiac arrest? Because it is just vibrating, it is not contracting. If it is just vibrating, there is no cardiac output. If there is no cardiac output, there will be no pulse at all. So if you feel the carotid pulse, you will not be feeling. So in and rhythm of a ventricular fibrillation, you need not feel the pulse at all in this patient. We can consider or take it for granted that this patient is in cardiac arrest. To summarize the tachyarrhythmia, what we have learned, which is very important from the resuscitation point of view, which will be learning the management of this, all the arrhythmias, what we have gone through it, we will be learning in depth in our resuscitation chapter. So have this basis good. So whenever we have a tachyarrhythmia, we'll look for the QRS complex. If the QRS complex is broad, then we have an ventricular fibrillation, what we are having. Monomorphic tachycardia is this, where the QRS morphology is same from beat to beat. And this is a polymorphic ventricular tachycardia, where the morphology of the QRS complex changes from beat to beat. Do not get confused with ventricular fibrillation to polymorphic VT. Polymorphic VT, the amplitude is quite high, which is not appreciated in ventricular fibrillation. If the QRS complex is narrow, then it can be supraventricular tachycardia, where the heart rate is more than 180. There is no P wave and rhythm is regular. If it is an atrial flutter, we are basically seeing for sawtooth appearance and the rhythm is regular. In atrial fibrillation, no P wave is seen, but the rhythm is irregular, what you need to remember. Some special rhythms we have already learned, that is a junctional rhythm. Junctional rhythm, there is no P wave and the heart rate is usually between 40 to 60. If the heart rate is more than 60 and up to 120 also, we will always consider this as an accelerated junctional rhythm with an AV dissociation. Non-sustained ventricular tachycardia is where there is an alteration between a monomorphic VT and an sinus rhythm. It is alternating between these two. This can continue like this, but do not get confused with PVCs. Whenever there is 3 consecutive PVCs are present, always consider is a non-sustained ventricular tachycardia. This treatment is different. It doesn't belong to the ALS algorithm at all. You need to treat it quite separately. Most of the time, these patients are stable. There is an underlying cause. Treat the underlying cause. Anyone has any doubts, please ask me. You can unmute yourself and ask me. Go ahead and ask me. These questions are very important. These rhythms, what we have learned, are very important from practical point of view if you're practicing the emergency department. Also from exam point of view, because this is one and better of the emergency medicine. You should be having a good hold of these rhythms. You should be able to recognize within fraction of a second all of these rhythms. So anyone having any questions, please unmute yourself and ask me, or you can type your questions what you're having in the chat box before we go ahead. All right, we'll be going ahead. Any questions?
Yes, sir. Good
Yeah.
afternoon. I'm just asked for idioventricular rhythm. Is it in only one lead or more than one lead?
It can be seen more than in one lead. In all the leads, it will be usually seen. You'll pick it up on the monitor itself. If you're 12 lead, if you get it like in monomorphic, it's the rhythm what you're having. So it cannot be in one lead and normal in another lead. So in all leads, you will pick up the idiosyncronized. But the thing what you need to remember, there should be a myocardial infarction. The heart rate should be between 130 to 150 and the patient should be stable. Then only we call it as that kind of rhythm. Otherwise, we usually do not consider as an idioventricular synchronized rhythm there. We will go further ahead, assuming that no one has any doubt. So we will be going further ahead into the abnormal P waves. These are not very important for us. Abnormal P waves are not very important for us. For example, if it is a right ventricular hypertrophy, the P wave will become more notched, or it will be tall, or the amplitude of the P wave increases. Sometimes it might be notched, known as M mitral, you can call it. It's basically seen in left atrial hypertrophy, not important for emergency doctors. What is important for emergency doctors is to find out whether there is an ventricular hypertrophy, right ventricular hypertrophy, or in left ventricular hypertrophy. We'll take a classical example here for often COPD patients for a decade, for a 10 years, he is having COPD, badly controlled. And eventually what will happen? The resistance in the lungs will increase. In the lungs, the resistance has increased. Because of increase in the resistance in the lungs, what has happened? This resistance, basically the increased pressure, this ventricle needs to hypertrophy. That means the musculature of the right ventricle should increase so that it can pump against the resistance what is present in the lungs. This happens over the decade of time, not in a recently diagnosed COPD. So how do you know what is the difference in the electrical activity which will happen? Because the right ventricle is thickened, the electrical activities what is happening in the right ventricle is much higher compared to the electrical activities what is happening in the left ventricle. Okay, this is an abnormality what we are having. That's why the V1 will be quite positive. V6 might not be positive at all. You can see here V1 is positive, but V6 is not positive. Usually what happens in a normal person, V1 will be negative and V6 will be positive. This is inverted. In normal person, the left ventricle muscle is quite thick because it has to pump the blood for the entire body. Here, what has happened, because of the increased resistance in your lungs, the right ventricle has hypertrophed. Because the right ventricle is hypertrophed, the electrical activity that is happening in the right ventricle is much, much, much more than that of the left side. For that reason, V1, V2, which are closer to the right side of the heart, becomes positive. V6, V5, V4, which are away from the right side of the heart, becomes negative, negative, negative. This is known as poor progression of the QRS complex here, which is classically seen in right ventricular hypertrophy. The same thing which I have written in the words, the additional thing what you need to remember is because there is a right ventricular hypertrophy, there will be a right axis deviation. RAD is seen. This is the normal cardiac axis. So it will be diverted towards the right side because the right musculature is increased and the electrical activity that is happening in the right side is increased. For that reason, the cardiac axis, which is normally in this direction, will be in this direction. If that is in that direction, lead 1 and lead 3 will be facing towards each other. These are like a married couple. They are facing towards each other. So right axis deviation, what you will be appreciating in these patients. Left ventricle hypertrophy is not that easy. We use few criteria to be here. One criteria what is very commonly used is known as voltage criteria. The S wave what you are seeing and the R wave what you are seeing either in V1 or V2, V5 or V6, you can take it, whichever the amplitude is high. Count the number of large boxes, 1, 2, 3, and 4, approximately 5, 6, 7, 8 large boxes what I am having here. If the large boxes are more than 7, then you call it as an left ventricular hypertrophy. More than 7 is nothing but 35 millimeters. Okay, each box is 5 mm. So if you take 7 boxes, it becomes 35 mm. So anything more than 35 mm, then we take it as an left ventricular hypertrophy. Along with it, most commonly the lateral rates V5 and V6, most commonly there is an ST sloping is present. You can see this sloping is present. Here the sloping is there. Here the sloping is present. Sloping is present. Let me show you again so that the understanding is better. So this sloping is present here. Sloping is present. Along with that, the T waves inverted, T waves inverted, sloping, sloping, inverted T wave, inverted T waves. This sloping of the ST segment with inverted T waves or sometimes even erect T waves, it's more commonly seen in left ventricular hypertrophy. So remember the voltage criteria. You take V1 plus V5 or V6, one of these leads, you can take it, add up. So S wave of the V1, that is the negative wave of the V1 plus positive wave of the V6 or V5, whichever the amplitude is more. Add together. If it is more than 7 large boxes, then you can consider left ventricular hypertrophy. Along with that, usually there is an ST segment depression with T wave inversion in V5 and V6, what you'll be seeing in left ventricular hypertrophy. When do you see an left ventricular hypertrophy? It has to again pump against the resistance. When do we see the resistance? For example, it might be an essential hypertension. The patient is having hypertension. That means the pressure is high in the artery. Aorta is also artery. The blood has to be pumped from the left ventricle into the aorta. So against the increased pressure, what is there in the aorta? Other example is aortic stenosis. In aortic stenosis, also it has to pump against the resistance of the stenosed wall. It is not opening easily. So it has to pump against the stenosed wall. So again, in these conditions, also left ventricular hypertrophy is very commonly seen. Now we are entering into ST and T wave patterns. We are not going into ST segment elevation myocardial infarction. This will be learning separately in cardiology chapter, so do not worry about this part of it. We are just worrying about any other condition than a proper ST segment elevation myocardial infarction. What are the other conditions? What are the other pathologies can be seen which might be equivalent to a myocardial infarction? What we are looking out for here. So soon after the end of the QRS complex, you call it as in J point. Okay, this is J point elevation if that point itself is elevated. If that point becomes notch, then we call it as an Osborne wave. Okay, remember that Osborne wave is notching which is present at the J point. You need to know what is J point. First thing what we are seeing is Brugada syndrome. Brugada syndrome, there are different types. Type 1, type 2, and type 3 Brugada syndrome. Most of the time, it is the type 1 what is tested in the exam, unlikely to be tested type 2 and type 3. Let us see each one of this, what is type 1, what is type 2, and type 3. In type 1, there is a code kind of code. This is known as code. Code kind of ST segment elevation, either in V1, V2, or V3. So at least in 2 leads should be there. Followed by T-wave inversion is seen. The same thing, ST segment elevation, that is code kind of ST segment elevation, followed by anti-wave inversion. Seen from V1 or V2 or V3, at least in 2 leads should be there. And it should be more than 2 mm. 2 mm means more than 2 small boxes should be present. Then we call it as an type 1 Brugada syndrome. What is type 2 Brugada syndrome? In type 2 Brugada syndrome, usually you will not be seeing T inversion. You are only seeing is ST segment elevation. So only saddle kind of ST segment elevation what you are seeing here. But this will be more than 2 mm. If this ECG finding or this ECG finding is less than 2 mm, we call it as a type 3 of the Brugada syndrome. But you can see here, it becomes very difficult to appreciate an type 2 or type 3. That's why it is very, very difficult to pick it up in a real life scenario. Hence, it doesn't appear in the examination. Whenever they want you to test you on the Brugada syndrome, this is the ECG what they will be testing you on. Why am I really worried about Brugada syndrome? Why I keep mentioning this as Brugada syndrome? I'm worried about this. Why? If someone who presents with, usually they present with an palpitation or a syncope. If they present with an syncope, basically they are predisposed to VT or VF. So this Brugada syndrome, who are having this ECG pattern can end up having an ventricular tachycardia and ventricular fibrillation, can go into an cardiac arrest and die. For this particular reason, I am really worried about this patient. If they present with a syncope, I do an ECG and pick up an Brugada syndrome, this patient needs to be admitted. Why needs to be admitted? For two reasons. They need to have an defibrillator implanted. That is an implantable cardioverter defibrillator, what we call it. It is a small device which is implanted subcutaneously in your chest. So whenever this patient have an VT or VF, it gives a shock. So appropriate joules of shock, it will be delivering it. For that reason, you need to admit it. What is the one more reason? Can you ask him to just follow up in the OPD and get an implantable defibrillator? No. This patient can have one more syncope. That syncope can result in VTR, VF. That can result in a cardiac arrest and the patient can die. So you cannot allow him to go out of the hospital. You need to admit this patient. So admit this patient. Okay, these things what you need to remember. One more thing is Brugada syndrome is an autosomal dominant disorder. So if you are, for example, an X person is carrying, having a Brugada syndrome, what are the chances of his kid having a Brugada syndrome? Around 50%. So this can be tested. It is more tested in the OSCE exam, can be tested in your exam also. So be aware of this part. If anyone who presents with an ECG, have the typical features of the Brugada syndrome. Can we label them as an Brugada? No, we cannot label them as Brugada unless they are presented within syncope, has a nocturnal agonal respiration, which is difficult to take an history and pick it up, has an code. Same kind of ECG pattern is seen in some family members. Yes, then you can label it. Or the patient has presented with a syncope, then you can label it. Or there is a family history of sudden cardiac death, then you can label it. Or you can documented ventricular fibrillation or polymorphic ventricular tachycardia is present in this patient, then you can label it. Or a VT can be programmed and electrically stimulated, then you can label it. You take an ECG for some other reason. For example, you need a cardiac clearance to get an surgery done. That's why you got an ECG done. And suddenly they have this Brugada, classical Brugada syndrome. What you do at that point of time? You just ask them to follow up with the cardiologist. Unless and until they have some of this. Why you want to follow up with the cardiologist? To do an programmed electrical stimulation so that they can induce the ventricular tachycardia. Or else, if the patient is having a family history of sudden cardiac deaths, or a family member having a Brugada syndrome, or the family member, or there is a documented VF or VT for that particular patient, or the patient had any times and syncope, then you need to admit this because this patient is definitely having a Brugada syndrome. So do not get confused. You cannot just say a patient is having a Brugada syndrome. One of these following should be present along with the ECG changes, what I have mentioned previously, to call it as a Brugada syndrome. Otherwise, it can be a normal variant also. What is D. Venter syndrome? D. Venters is a cardiologist. He's a professor. He's a cardiologist. What he did? What he did is he noticed in his department that many patients with an LAD block, okay, LAD occlusion is there. Proper atherosclerotic LAD occlusion is there in those patients. But typical ST segment elevation changes were not seen. So what he did is he collected all the ECGs of those patients and compared with that and saw an pattern what is developed. All these patients had a pattern. That pattern is labeled as with the scientist name itself or the professor's name itself, which is known as D. Venters. What he noticed is in the chest leads, what you can see is there is an ST segment depression with tall, big T waves. Not big, tall T waves. Tall T waves are seen in all the chest leads along with ST segment depression. Whenever we say ST segment depression, you need to see the isoelectrical point. Isoelectrical point is the point between the T wave and the P wave. That is known as isoelectrical point. When you're seeing an isoelectrical point, there is an ST segment elevation and there is a tall T wave. Consider this as an D-Venter syndrome if the patient has presented with classical signs and symptoms suggestive of an myocardial infarction. For example, a patient has come in with a chest pain. You got a ECG done. This is stemming. Okay, this needs to be considered as an occlusion of an LAD. One more condition, this is the same thing what I have written in the groups, but what I have told, if you remember, that should be more than enough. Another condition is known as Valence syndrome. Valence syndrome also classically presents with a chest pain which has resolved now. By the time you are taking the ECG, chest pain has resolved. Okay, this Valence syndrome is seen if there is a stenosis. It is not an occlusion, it's a stenosis, stiffening of the wall of the LAD is present. Then you consider as a Valence syndrome. Valence syndrome, there are two kinds of Valence syndrome. One is deep inverted T waves if seen in lead 2 and 3, it is a Valence syndrome. If biphasic T waves, there is a positive deflection, there is a negative deflection. There is a positive deflection, there is a negative deflection of the T wave. Positive deflection, negative deflection of the T wave is present in V2 or V3. We're not seeing any other leads. People get confused here. You're only seeing in V2 or V3. Do not see any other just leads at all. If there is a biphasic T wave which is present in V2 or V3, you call it as an Valence syndrome. This also needs to be given as important as an ST segment myocardial infarction, and the treatment should be similar to an ST segment myocardial infarction. Holds good for Valence syndrome, holds good for D. Venters syndrome. Treat it like an ST segment elevation myocardial infarction, which we'll be learning in the cardiology chapter. I will be mentioning D. Venters syndrome and Valence syndrome in cardiology chapter, so be aware of that. I want you to answer in the cardiology chapter. I want you to be aware of this ECG patterns in the cardiology chapter. Let's take in proper ECG. We are taking V2 and V3. We are seeing in biphasic T wave pattern, biphasic T wave pattern. This is Valence syndrome. Again, deep inverted T waves are seen in V2 and V3. This is also an Valence syndrome what we are having. Next we are seeing is an Osborne wave. Still we are in a T waves segment we are still there. Osborne wave is nothing but notching at the J point. Whenever there is a notch which is present at the J point, then it is known as Osborne wave. And this Osborne wave is seen in hypothermia, also seen in hypercalcemia. So do not forget, it is seen in two conditions. It is not an pathognomic feature of hypothermia only. It is also seen in hypercalcemia, which we'll be seeing in coming up slides. So a notch which is seen at the J point, a notch which is seen at the J point is known as Osborne wave. What is the digoxin effect on the ECG? Simple thing to remember, whenever the digoxin effect is on the ECG, it is an inverted T mark. So anyone who is taking a digoxin, a completely stable patient who is on digoxin, might be for any reason, for example, for an heart failure. If you get an ECG done, you see a reverse tick mark. This is a normal tick mark. This is a reverse tick mark what you're having. Let us see what do I mean by reverse tick mark. This is the reverse tick mark. So it looks reversed. It looks reversed. Again, it looks reversed. This is known as reverse tick mark sign, typically seen as a digoxin. It is not digoxin toxicity. Whenever you are having an digoxin toxicity, then you can have an supraventricular tachycardia, like an atrial flutter the patient might be having. It can be atrial fibrillation the patient might be having. It can be an supraventricular tachycardia. Sometimes they might be having blocks, like a first degree or second degree or third degree or complete heart block, third degree heart block. Those patients can be having. Most of the time, they present with a typical rhythm known as bigeminy or a trigeminy. What is bigeminy? A normal QRS complex followed by an PVC, premature ventricular contraction. Again, normal QRS complex, a PVC. So bigeminy, it is a pairing what is present. That's why it is known as bigeminy. Two normal QRS complexes what you are having. Then suddenly you have an premature ventricular contraction. This is known as trigeminy. This is one set. There are three QRS complexes. That's why it is known as tri. There is one more tri here. This is known as trigeminy. Bigeminy PVCs or trigeminy PVCs are very commonly seen in digoxin toxicity. Digoxin toxicity can produce an atrial fibrillation. It can produce an SVT. It can produce an atrial flutter. All these are nothing but supraventricular rhythms they are. So any of these rhythms this patient can be having. Before I enter into the electrolyte abnormalities and their ECG patterns, different ECG patterns, anyone has any questions, you can pop up now and ask me. I do not see any questions in the meeting chat. So anyone has any questions, just type and let me know. We'll enter into the electrolyte imbalances. First one, what we are seeing is hyperkalemia. Depending on the severity of the hyperkalemia, the ECG changes are also seen. For example, if the severity, it is a mild hyperkalemia the patient is having. If the patient is having a mild hyperkalemia, usually peaked T waves are seen or might not seen. ECG pattern might be completely normal. If it's a moderate kind of between 6.5 to 7, it is mainly the P and the PR interval changes are seen. What happens to the P wave? P wave becomes broad, 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 and it suddenly becomes flat. So it is a normal P wave or broad P wave or broader P wave, and suddenly it becomes flat. Okay. Along with it, there is a PR prolongation, what you're seeing. So P wave, which becomes widening, 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 or broad, 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 and suddenly it disappears, and there is a prolonged PR interval, what you're saying. Later on, what you see is there is a prolongation of everything, especially the QRS complex becomes bizarrely broad, it becomes. Okay, and it goes into blocks. So bradycardia is seen. It might be an first degree, second degree, third degree heart blocks can be seen. And it becomes very broad, broad, broad. Then it is known as sinusoidal rhythm. Sinusoidal rhythm. After sinusoidal rhythm, usually they enter into an asystole or a cardiac arrest asystole. So remember, first what you're seeing is a tall peak T wave, then P and PR complexes. So it becomes broad, 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 and flat, and PR interval increases. Then QRS complex becomes broad and gets a bizarre rhythm known as sinusoidal rhythm. This sinusoidal rhythm will eventually result into an complete asystole. So what are we seeing here in this ECG? Is a tall T wave. Everyone agrees with it, but they forget to say peaked. It's just not enough to have a tall T wave. It should be peaked. Peaked means it's like a tent. It has a peak here. So tall P wave, which is peaked, 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 peaked appearance, peaked appearance. This is a typical feature of hyperkalemia, what you are having. What is this wave? Let's break down this and see. This is the P wave, which is getting flattened and flattened. The PR interval obviously looks broad. The QRS complex is very broad here. So this whole thing, what is known as is sinusoidal rhythm. This whole thing is known as sinusoidal rhythm. So this at any point of time can go into asystole. This ECG pattern was given a few days back and they wanted to know what will be the further management, what you'll be doing. You need to treat the hyperkalemia. How do we treat an hyperkalemia if there is an ECG change? By giving calcium supplement for the patient intravenously as soon as possible. Do not worry, we'll be learning about the hyperkalemia treatment in coming up chapters. This is also a sinusoidal where P wave is completely flat and you cannot appreciate at all. QRS complex is broad. The rhythm looks very bizarre. This is known as sinusoidal pattern. Hypokalemia. What do we see in hypokalemia? The amplitude of the P wave increases. The PR interval will increase. At the same point of time, there is widespread T wave flattening or inversion. So T wave can be inverted or T wave can be just flat. After the T wave, there is one more positive deflection which appears, which is known as U wave. Most of the time, what happens in this condition, QT prolongation is not very specific for hypokalemia. Why it is not specific? So this is the QRS complex what you are having. T wave what you are having is flattened. Then you are having a positive deflection. So we do not know this positive deflection is because of T wave or U wave what you are having. So if you consider this as an QT interval, QT prolongation is seen, they say sometimes, but it is a pseudo or apparent long QT interval, we call it. It is not a true QT prolongation what you're seeing here. So unlikely this patient is predisposed to torsades, which is nothing but polymorphic ventricular tachycardia. Remember that polymorphic ventricular tachycardia is also known as torsades. Both means one and the same, which I forgot to mention there. Polymorphic ventricular tachycardia means the same, that is torsades. QT prolongation is a pseudo QT prolongation or an apparent long QT interval, what you'll be seeing in hypokalemia. So let us break down and have a look at the things what you're seeing. PR interval is increased, yes. P wave looks very prominent, yes. T wave looks flattened, yes. There is one more positive deflection which has which has appeared here. That is U wave. So this is the U wave what you are seeing. This is the T wave which is inverted, and this is the P wave what you are seeing. So it becomes difficult to differentiate between U wave and T wave. So remember that point. That's why if you consider this as an T wave and this as an QT interval, it is obviously prolonged because we are aware of the thumb line that is between two RR waves. If this is towards this QRS complex, then you call it as a prolonged QT interval. If this was here, then we call it as a normal QT interval, what you need to remember. So hypokalemia, what happens? T wave gets inverted or depressed or flattened and a U wave appears. This is hypokalemia. It's like someone is pressing down. Hyperkalemia, someone is pulling the T wave up. So tall peaked T wave, what you're seeing along with increased in PR interval and broad QRS complexes are seen in hyperkalemia. Hypercalcemia. Hypercalcemia, I already told you that Osborn waves are seen. Along with it, there is a short QT interval. Only two things what you need to remember. Short QT interval and Osborn waves which are seen. Osborn waves, is it Osborn waves is seen here? Yes, there is a notching what is seen. This notch what you are seeing is an Osborn wave. Along with it, T wave is not very well appreciated, but this is the T wave what you are having here. This is the T wave. It looks quite short. It looks like, if you calculate and see, it looks like less than 30 milliseconds. Short QT interval, you need to calculate with the formula, otherwise we'll be not having. So measured QT interval divided by square root of R interval, that will give you the QT interval. If the QT interval is approximately less than 350 milliseconds, then we call it as a short QT interval. Hypocalcemia. Hypocalcemia, the thing what you need to remember, most important thing is prolonged QT interval. Prolonged QT interval will predispose to torsades. So what are you seeing here? This is a QRS complex. This is a QRS complex and QT interval ends here. It is towards this QRS complex. Hence, it is a prolonged QT interval. So one of the causes for prolonged QT interval is hypocalcemia. We are worried about this prolonged QT interval because it predisposes to torsades. That is nothing but polymorphic ventricular tachycardia. Same thing holds good for hypomagnesemia. Only two things what you will be remembering is prolonged QT interval which predispose to torsades. So the ECG changes what you see in hypocalcemia and hypomagnesemia are one and the same, or the important features are one and the same, what you need to remember. So you need to get in blood investigations done to really differentiate between an hypomagnesemia or hypocalcemia which is causing it. But most common cause for prolonged QT interval which predisposes to torsade point is that is polymorphic ventricular tachycardia is hypomagnesemia. So you know it. It is hypomagnesemia most of the time, 90% of the time. So blindly you can treat it till you have the blood investigations available. If the patient is in this rhythm is nothing but polymorphic ventricular tachycardia. To differentiate between hypercalcemia and hypocalcemia, hypo prolonged QT interval, hyper short QT interval, what you need to remember. So this is the summary of everything what we have learned so far. For example, sinus arrhythmia. P wave is present. Yes. Rhythm is irregular. Sinus bradycardia. Rhythm is regular. PR interval is normal. And the heart rate is less than 60. That's why we call it as sinus bradycardia. Sixth sinus syndrome. Sometimes normal PR intervals you are having a normal. Suddenly there is no electrical activity at all. Sinus, it goes into sinus tachy, sinus brady, alternating between the two. Junctional rhythm, no P wave or absent of the P wave, rhythm is regular and heart rate is between 40 to 60. If the heart rate is between 60 to 100 up to 120 also, we consider it as an accelerated junctional rhythm with AV dissociation. Atrial flutter, always remember sawtooth appearance and the rhythm is regular. Atrial flutter, there is absent P wave and irregular rhythm, or basically rhythm is irregular. Supraventricular tachycardia, absent P wave, regular rhythm, and heart rate is more than 150. Most of the time, it is more than 180. Monomorphic ventricular tachycardia. QRS morphology is bizarre, but this QRS morphology is same from one beat to another beat. That's why we call it as a monomorphic ventricular tachycardia. Polymorphic, the rhythm changes. This is a polymorphic ventricular tachycardia, which is also known as torsade pointis. Non-sustained ventricular tachycardia is interchanging between a sinus rhythm and ventricular tachycardia. We call it as a ventricular tachycardia because there are more than or equal to 3 PVCs. Ventricular fibrillation, it is a chaotic rhythm what you are having with various varying amplitude. It can be a fine where a line looks slightly blurred line, or it might be a course like this, which is quite different from that of the ventricular tachycardia. This is a ventricular fibrillation. Whenever the patient is ventricular fibrillation, we suspect the patient to be in cardiac arrest. Digoxin. Digoxin effect itself becomes a reverse stigma, but toxicity can cause an bigeminy or trigeminy or any supraventricular rhythms can present like an SVT or an AF or an atrial flutter can be there, for example. Hypothermia, typical Osborne wave, which is not typical only for hypothermia. It is also seen in hypercalcemia along with short QT interval. Hyperkalemia, we have various changes from tall tick P waves to a flat P wave to an PR prolongation to a broad QRS complex to a sinusoidal pattern to an asystole. Hypokalemia, prominent P waves with a prolonged PR interval, flat T waves or inverted T waves followed by U wave. Hypocalcemia is one of the causes. Hypocalcemia and hypomagnesemia both kind of join together and go ahead to go to produce an QT interval, and torsade point is what you need to remember. Anyone has any questions, you can ask me before we go into few of the recall questions what we are having. Not all the recall questions, because most of these recall questions we will be applying the ECG what we have learned in the cardiology and the resuscitation chapters. So maximum questions are there in the cardiology and resuscitation chapters. And we are discussing few questions for one more reason is we are waiting for this diet exam, which is not yet been happened, which will be happening tomorrow on 12th. So we are waiting for the questions from my last batch students. I'm hoping they will help me out to collect the questions. With those questions, we can come up with an complete recall questions of the last that also. So we'll distribute according to the chapter. We'll be going through them. Till here in the ECGs, if anyone has any doubts, please feel free to ask before we go into a few of the recall questions what we are discussing now.
Hello.
Yes, I can
Hello.
hear you. Go ahead.
Sir, actually, I have one question regarding digoxin toxicity.
Yes.
Is there atrial fibrillation will be occur, or
Yes,
except
can occur.
atrial fibrillation, other thing will occur?
Atrial fibrillation can happen because of the digoxin toxicity.
Okay, another question is regarding hypo and hyperkalemia. PR will be prolongation in both type, both
Both it
cases.
is seen. Most other, yeah, both in both intervals can be seen in hypo as well as hyper. It can be seen PR prolongation.
Okay, thank you, sir.
But P wave kind of disappears in, that will help you to differentiate. P waves kind of disappears in an hyper, but in an hypo, it becomes quite prominent. Anyone else have any questions? Feel free to ask.
Yeah, regarding valence, you mentioned that if it's regarded as STEMI. So if not in pain, do we still do PCI or thrombolysis treat?
Usually what you need to consider when you're diagnosing for an Wellens syndrome here, what I mentioned, I'll show you. When you're diagnosing for an Wellens syndrome, the prerequisite is this patient should have had a recent chest pain which has resolved. For example, I've been having this chest pain, just coming to the, before coming to the emergency, it is gone completely. I do not have a chest syndrome. Then you are seeing this pattern. Then you need to involve the cardiologist and do it because it is a critical stenosis where he is having the ischemic features, which needs to be opened. Or basically they place a stunt, they do some drilling and place a stunt because there is a critical stenosis which is present.
Okay, thank you.
Anyone else have any questions? All right, then we'll go into the recall questions what we are having here. So we'll be discussing the recall questions what we'll be having here. So keep yourself muted unless and until you want to answer or you have any doubts, you can ask me. When I'm reading the question, please do not interrupt in between. Otherwise, I might have to mute everyone at the same point of time. Okay, because it will disturb the class for that particular reason. So the question what we are having here is a 76 years old presented to the emergency department with a palpitation seen by an FI1 doctor. He discusses the case with you and says that patient is having a ventricular tachycardia and asks for your help. On reviewing the ECG, you are sure it is an supraventricular tachycardia with an aberrant block. Which of the following features? They're not asking about the ECG. Which of these following features favors an SVT with an aberrant block? They are asking. If this feature is present, it is more suggestive of an SVT rather than an VT. Which one? Anyone?
RBBB morphology.
Yes. The right answer here is the RBBB morphology. Capture beats and fusion beats are only seen in ventricular tachycardia, cannot be seen in VT. Extreme axis deviation is nothing but a positive AVR, what we are seeing, which is commonly seen in ventricular tachycardias. Very broad QRS complex. A broad QRS complex can be seen in SVT with apparent block, but very broad QRS complex, most of the time it is seen in ventricular tachycardia. So this is the same thing, what I have repeated. Next question, what we are going here is a 21 years old female presents with an syncope to the emergency department. She had an similar episodes 2 days back. An ECG of the patient was taken and it is shown below. Vitals are given which are completely stable. What is the most likely cause for the syncope? They are asking. So what is the ECG suggestive of? First, let us see the ECG. What is the ECG suggestive of? It's a Brugada syndrome, what we are seeing here, because there is an chord ST segment elevation along with the T wave inversion seen in at least 2 leads of V1, V2, V3, which is a classical description of Brugada. Can I label it as a Brugada syndrome? Yes, I can label it as a Brugada syndrome because the patient had a syncope. So I have a reason to label it as a Brugada syndrome. So I have labeled it as an Brugada syndrome. But there is none of the following options are mentioned here. Why? They're asking why is the syncope likely? Because this Brugada syndrome can predispose to VT or VF. So most likely because of a ventricular tachycardia, this patient had an syncope, which has self-reverted back into the sinus rhythm. That's why he has gained the consciousness and come back to the emergency department. If it was in sustained ventricular tachycardia, he would have gone into an cardiac arrest. So this patient is having an ventricular tachycardia, had an ventricular tachycardia at the time of syncope. So the cause for the syncope is ventricular tachycardia. Predisposing factor is an Brugada syndrome. That's what you need to remember. So this is known as two-step question. One step was to find out the ECG pattern and know that this is an Brugada syndrome. Second step was this Brugada syndrome can predispose to VT and VF you need to be aware of. So this is a step 1 question and this is the step 2. So this is known as step 2 questions. More and more Over the time, over the diets, what are coming, step 2 questions are becoming more and more common. So be aware of the step 2 questions. Over the time, if you keep on practicing, you will be very well aware of, so it will be easier for you to deal with it. A 34 years old male present to the emergency department with a syncope while playing football. There are no obvious external injuries sustained. On examination, the patient seems to be completely stable. The ECG is given to you. What is the most likely diagnosis? Here is this is a single step question. Only one step is present here. There are no multiple steps. So you're seeing the ECG. ECG is suggestive of an biphasic ECG is suggestive of an ST segment elevation with the T wave inversion which is present in V2 and V1, which is suggestive of an Brugada syndrome. Feel free to stop me at any point of time if you have any question. Next question what we are having is a 44 years old male present to the emergency department with the complaints of transient loss of consciousness. Transient loss of consciousness or in syncope means one and the same. At his workplace while he was working on his laptop, a nurse at the triage has checked his vitals and done an ECG as shown below. Given below ECG is suggestive of what they are asking. So what is this ECG suggestive of? Let us break down the ECG what we are having. Can I see an P wave here? There is no P wave what I am seeing. Is the rhythm regular? Yes, this RR interval is same as this RR interval or this RR interval. So it is a regular rhythm what I am having. What else I am seeing here? Let me calculate the heart rate. Approximately 3 large boxes what are present. So 300 divided by 3 large boxes. So approximately 100 the heart rate. Heart rate is 100. So keeping all this in mind, which is the rhythm what we need to think of? Anyone?
Accelerated.
Yes.
Accelerated
Accelerated
junctional.
Junctional rhythm.
junctional
It's
rhythm.
an accelerated junctional rhythm. If the heart rate is between, for example, if this heart rate is 48, so it will be just,
Junctional rhythm.
Junctional rhythm.
then would have been just an junctional rhythm. It's the same thing, same ECG is what we are seeing here. Instead of regular type, make it as an irregular. So it will become,
Atrial fibrillation.
yes, good. So it will become an atrial fibrillation. Same ECG, regular rhythm itself, no P wave itself, heart rate, I'll increase it to 190. So it will become
SVT.
SVT.
Supraventricular tachycardia.
So whenever you're seeing this question, see what are the different, ask yourself so that it kind of helps you to revise at the same point of time, it sits in your mind. So whenever you're seeing an ECG in the emergency department, so think, I have learned the ECG, so I should be able to make a diagnosis here. So make a diagnosis and see whether you are correct or wrong. Discuss with the cardiologist, you'll come to know whether it is correct or wrong. An elderly male collapsed at an care home. Paramedics had retrieved the patient from the care home and brought him to the emergency department. An ECG was taken by the junior doctor as shown below. The junior doctor requests your help. Okay. This much doesn't have anything related to the question what they are asking. They're basically asking the ECG below is suggestive of what? Okay. Only the ECG what they are given, what it is suggestive of. Just looking at it, I know it looks like a very slow heart rate because there are number of 1, 2, 3, 4, 5, 6, 7. 7 large boxes are there. This is a bradycardia. Whenever the bradycardia comes in mind, 2 questions you need to ask yourself. Does every P wave have an QRS complex? This P wave doesn't have a QRS complex. This P wave doesn't have. This P wave doesn't have. So answer is no. Does every QRS complex has a P wave? Yes. This one has it. This one has it. This one has it. Even this one, even this one, even this one. So next answer is yes. So if one question is yes and another question is no, we know it is an second degree heart block. Okay, second degree heart block. It is of 2 types, type 1 and type 2. We usually see the PR interval. In this patient, to see the PR interval, there is an issue with the PR interval. So you're seeing this PR interval, but nothing is there to compare with the PR interval before there is a loss of beat. Because after P wave, there is no QRS complex, loss of beat is there. So what to do in these circumstances where I am not able to compare the PR interval? Then you will be seeing the QRS complex. If the QRS complex is narrow, then it is type 1. If the QRS complex is broad, then it is type 2. Okay, this we are entering into the depth of the ECGs. That's why I'm talking about. Someone who doesn't know or aware of this, when you're not able to compare the PR interval, we look the QRS complex, they go wrong at that point of time. So this ECG is suggestive of Morbitz type 1. In success, if you're doing in success something, you might come across an ECG, and this ECG, they might call it as in type 2. No, it is wrong. It is not Morbid's type 2 block. Okay. So be aware of this one. You can, if you are doubting me, you can always go and open Tintinelli or Rosen's or any good ECG book. They have mentioned it. Okay, it is clearly mentioned in Tintinelli, what I have read and what I have come across, and a lot of ECG books I've cross-checked. This is what they follow if you're not able to compare the PR interval. Okay, so the right answer here is Morbus type 1. Same patient, if this QRS complex was broad, then I would have labeled it as a Morbus type 2. It's the same thing, explanation what I have written here. Nothing different. Anyone, any doubts here? Okay, let's go with the next one. A 64 years old patient was brought to the emergency department in an ambulance. He complains of lightheadedness, which has been on and off since last 2 days. It has worsened since morning. A ECG was taken and is shown below here above. What is the most likely cause of his lightheadedness? What is the ECG? ECG diagnosis they are asking. So let's break down. This is a very slow or bradycardic ECG what I am having. Does every P wave has a QRS complex? No. Does every QRS complex has a P wave? Again, no. This QRS complex doesn't have a P wave. No and no. So it is a complete heart block. I am seeing an RSR dash pattern suggestive of an right bundle branch block. I see an lead 1 and lead 3. Lead 1 is positive. Lead 3 is negative. They are looking opposite to each other. They are like diverged couple. This is suggestive of an left axis deviation. A left axis deviation plus an RBBB plus an complete heart block is suggestive of a complete trifascicular block. So this is a complete trifascicular block what the patient is having. To call it as an incomplete trifascicular block, it has to be first or second. Instead of this complete heart block, it should have been a first degree heart block or a second degree heart block to call it as an incomplete trifascicular block. So what you are seeing ECG here is suggestive of a complete trifascicular block. So never stop at an complete heart block. Look at the other features also. Two important features what you need to look out for. One is RBBB pattern. Another one is left axis deviation. If they are present or absent. If they are present, both of these features, then you will call it as a trifascicular block. Do not forget to check. Most of the time, what they do in the examination is they see the heart rate. Okay, it is very slow. Okay, then they ask themselves the two questions, and it is a complete heart block, and choose a complete heart block what is present here. No, it doesn't stop. They check for RBBB, that is RSR dash pattern is there. Check for LAD pattern is there, that is positive 1 and negative lead 3. Yes, present. So it is an complete trifascicular block. Next question. Anyone? Any doubts? Okay, let's go into the next question. A 78 years old male, a known case of decompensated heart failure, came to the emergency department with a possible overdose of a prescription medication due to an worsening bilateral lower limb swelling, which has hampered his daily activities. On questioning, he does not remember the name of the prescription drug. On examination, the patient is conscious, oriented with a GCS of 15. The nurse has taken the ECG at the trial and shown below. According to the ECG, what is the most likely drug he has taken, which has overdosed himself? Anyone wants to tell the findings in the ECG and make a diagnosis?
Reverse tick marks.
Reverse
Digoxin.
tick mark.
Digoxin.
Digoxin.
I do agree there is a reverse tick mark. But what is the ECG suggestive of? Reverse tick mark, yes, digoxin. I do not want to stop here. What is the ECG suggestive of? Yes, AF.
Irregular.
So most likely he has overdosed with in digoxin because ECG is suggestive of an reverse tick mark. So he's taking digoxin. Overdose of digoxin can lead to any supraventricular tachycardia or supraventricular rhythms like an SVT, AF, or atrial flutter. This patient is having an AF, he is having an AF, atrial fibrillation. So the right diagnosis is he is taking an digoxin. Digoxin is a commonly used drug for heart failure. If the ejection fraction is very low, usually less than 25, they usually add up the digoxin so that the ejection fraction increases. Most of the time for the heart failure, the first choice of drug is furosemide. So this question can be tested. Same question they can give it. Okay. And in the ECG pattern, they might come up with an U wave or along with an inverted T wave. So what is the most likely drug he's taking?
Furosemide.
Furosemide. Furosemide.
Furosemide is known to cause hypokalemia. So hypokalemic changes is what I'm describing here. So it becomes a two-step question. So think yourself in this manner. So it will help you to reinforce the changes and correlate with the drugs also. A 29 years old female present to the ED complaining that her heart is pounding. That is basically palpitations. Pounding means palpitations. On further questioning, she says it lasted for around half an hour. She had similar complaints last week too. Currently, the patient is asymptomatic. On examination, she is comfortably sitting on the chair without any discomfort. Vital parameters are within normal limits. ECG is shown. What is the finding on the ECG?
Delta wave is
Slurred upstroke of the
Slurred
QRS
upstroke.
complex.
WPW.
Yes. All of you are right. So what are we seeing here is the slurred upstroke of the QRS complex, which is known as delta wave. Along with it, there is a short PR interval also. Combination of a short PR interval and a delta wave is known as WPW syndrome. Why do you think this patient had an palpitations? Because WPW syndrome predisposes to what? Anyone? It either predisposes to supraventricular tachycardia or an atrial fibrillation. That's why they usually have the palpitations. Okay, so this patient most likely had an SVT or AF when she was experiencing the pounding of the chest what they are having. So here the right answer here is the delta wave what you're seeing in the ECG. They're just asking the finding on the ECG. It's a single step question what you're having. Similar thing, they might ask you, what is the reason for palpitations in this patient or the pounding of the chest what the patient was having? So they can give an option as an VT and VF, monomorphic VT or polymorphic ventricular tachycardia, they can give it. And more options, they can give it like an, sorry, like an atrial flutter the patient is having, a sinus tachycardia, they might ask you. Then you need to choose which one is the right one, an atrial fibrillation. So atrial fibrillation is the reason this patient has a pounding. So remember, it's an SVT or an AF, what an WPW or an LGL syndrome predisposes to. So you need to be aware of. Brugada syndrome predisposes to VT or VF. LGL or WPW syndrome predisposes to an supraventricular tachycardia or an atrial fibrillation. Anyone has any questions till now, you can ask me before or the class ends here. Thank you, everyone. The class ends here. You're free to discuss any doubts if you're having in the in the group. But if you're having anything personalized, I usually recommend you to go ahead and discuss these questions or personal thing what you're having, message me personally. For example, you are having some software issues or your mobile is not working. All those things do not put up in the group. It is solely meant for discussion. Main reason for this is there are many other people. I do not want any of them to get disturbed. If something comes on the group, it should be important for you. So you directly go ahead and open and see. Someone shouldn't feel, what is this? I was busy in the emergency and I opened it and it was just nothing related to me. No, whenever there is something in the group, it should be important or it should be useful to everyone. For that particular reason, I am telling you. One of the question is, Valence, if not in pain, do we do an PCI thrombolysis? No, we do not do thrombolysis at all. Usually it is not recommended. But again, it depends on the cardiologist. We do not do it. We just refer to the cardiologist. Okay, if there is no chest pain, then it is not, we are not suspecting it to be an myocardial infarction. There are various other reasons which can cause an deep inverted T waves. So it should be a chest pain presenting with typical features of Valence syndrome, then only we consider it as an Valence syndrome and send it for PCI. Otherwise, you need to see, are there any other causes which is causing an inverted deep T wave? Any other questions? That's all in the messages what I am having. Okay, I'm expecting everyone has been benefited with this class. Thank you, everyone.
Thank you, sir.